Hi, this is Dr. Dawn Shepard. This lecture focuses on the clinical management of mood disorders, specifically bipolar disorder and major depressive disorder, using a practical decision-making framework drawn from Carlat and DSM-5 concepts. A central priority is accurately identifying a history of mania or hypomania, because bipolar disorder can be frequently misdiagnosed as unipolar depression when patients present during depressive episodes, which can lead to inappropriate antidepressant use and mood destabilization. We will apply the DIGFAST criteria to systematically assess mania, differentiate bipolar 1 from bipolar 2 based on severity, duration, and impairment, and then move into treatment strategies that emphasize starting a mood stabilizer such as lithium or valproic acid in combination with an antipsychotic for acute mania, with benzodiazepines used short-term for agitation. We will also address how bipolar depression differs from major depressive disorder in both presentation and treatment approach, and review how to select antidepressants based on symptom profile, comorbidities, and safety considerations while recognizing when to escalate to ECT or TMS. Throughout the lecture, the focus is on clinical accuracy, avoiding common diagnostic errors, and making treatment decisions that stabilize patients and reduce risk over time. The most important clinical task in diagnosing bipolar disorder is establishing a clear history of mania, because patients almost always present during depressive episodes and often do not recognize or report past manic symptoms. Bipolar 1 requires at least one full manic episode lasting 7 days or requiring hospitalization, while bipolar 2 requires at least one hypomanic episode lasting at least 4 days plus a major depressive episode with no history of full mania. To systematically assess mania, use the DIGFAST mnemonic: distractibility, indiscretion or risky behavior, grandiosity, flight of ideas, increased goal-directed activity, decreased need for sleep, and talkativeness, with at least 3 symptoms, or 4 if mood is only irritable, present during the same period. A key clinical distinction is that mania causes marked impairment, may include psychosis, and often leads to hospitalization, whereas hypomania does not significantly impair functioning and has no psychotic features. In practice, screening questions should anchor the patient to their most severe period of elevated mood, such as asking whether there was a time they slept only a few hours but still had high energy, and then walking through each DIGFAST symptom to confirm duration, severity, and functional impact. The treatment of acute mania should begin with combination therapy using a mood stabilizer and an antipsychotic, as this approach provides faster and more complete symptom control than either alone, particularly in moderate to severe mania. Lithium is a first-line option with strong evidence for reducing suicide risk and stabilizing mood across phases. For acute mania, target serum levels are typically 0.8 to 1.2 milliequivalents per liter, with closer monitoring required due to its narrow therapeutic index and lower targets used in older adults or medically complex patients. Valproic acid is also first-line and often preferred in acute or inpatient settings because it can be rapidly loaded at 20 to 30 milligrams per kilogram to achieve therapeutic levels quickly, with target levels generally between 50 to 125 micrograms per milliliter, making it useful for patients with severe agitation, mixed features, or when lithium is contraindicated. Carbamazepine is considered second-line due to drug interactions and side effect burden, but may be useful in certain cases. Antipsychotics are added for rapid control of agitation, psychosis, and behavioral dysregulation. Olanzapine and quetiapine are highly effective for acute stabilization, but carry significant metabolic risks. Quetiapine also has evidence for bipolar depression at lower doses around 300 milligrams per day, while aripiprazole is a better-tolerated option for long-term use due to its partial dopamine agonist mechanism, but may be less sedating in highly agitated patients. And haloperidol remains a potent option for rapid control in inpatient settings but has a higher risk of extrapyramidal symptoms. Benzodiazepines such as lorazepam or clonazepam may be used short-term for severe agitation or insomnia, but should only serve as a bridge while mood stabilizers and antipsychotics take effect. Medication selection should follow avoid by condition principles. Avoid lithium in renal disease, dehydration, or significant sodium imbalance. Avoid valproic acid and carbamazepine in liver disease and pregnancy. Avoid metabolically heavy antipsychotics like olanzapine and quetiapine in patients with obesity, diabetes, or metabolic syndrome, and use caution with high-potency agents like haloperidol in patients at risk for extrapyramidal symptoms, with the overall goal being rapid stabilization followed by transition to a safe, tolerable, and sustainable maintenance regimen. Now we shift into bipolar depression, which requires a fundamentally different treatment approach than mania because antidepressant monotherapy can destabilize mood and precipitate mania or rapid cycling if bipolar disorder is not recognized. First-line treatment should prioritize FDA-approved agents for bipolar depression, including quetiapine, lurasidone, cariprazine, lumateperone, and the olanzapine-fluoxetine combination, all of which have demonstrated efficacy without significantly increasing the risk of mood switching. Quetiapine is effective as monotherapy, typically around 300 milligrams at night, but carries significant sedation and metabolic risks, making it less ideal in patients with obesity or diabetes. Lurasidone is approved as monotherapy and adjunctive therapy, started at 20 milligrams daily with food, and is often preferred when minimizing weight gain is important. Cariprazine is dosed lower in bipolar depression at 1.5 to 3 milligrams daily and is particularly useful when depressive symptoms occur alongside mixed or residual manic features. Lumateperone is a newer option given as a fixed 42 milligrams daily dose without titration and is generally well tolerated with a lower metabolic burden. The olanzapine-fluoxetine combination can be highly effective but is often reserved for more severe or treatment-resistant cases due to significant metabolic risk. Lamotrigine plays an important role in maintenance and prevention of depressive episodes but requires slow titration and is not effective for acute symptom relief. Antidepressants such as SSRIs or bupropion may be used cautiously as adjuncts, but only in combination with a mood stabilizer or antipsychotic and never as monotherapy due to the risk of inducing mania. Bupropion may be chosen for its lower risk of sexual side effects and weight gain, but still carries activation risk. Medication selection should follow avoid by condition principles. Avoid activating agents in patients with anxiety, insomnia, or agitation. Avoid lamotrigine when rapid symptom control is needed. Use caution with metabolically active agents in patients with obesity or diabetes. And always reassess for a history of mania before initiating antidepressants, because misdiagnosing bipolar depression as unipolar depression is one of the most common and clinically significant treatment errors. When evaluating depressive symptoms, the priority is accurate diagnosis using DSM-5 TR criteria while simultaneously ruling out conditions that change treatment. A major depressive episode requires at least 5 symptoms over a 2-week period, with one being either depressed mood or anhedonia, along with changes in sleep, appetite, energy, concentration, psychomotor activity, guilt, or suicidal ideation. And these symptoms must cause clinically significant distress or impairment. However, diagnosis does not stop at symptom counting. Clinicians must actively rule out bipolar disorder by assessing for any history of mania or hypomania, because this immediately shifts treatment away from antidepressant monotherapy. Persistent depressive disorder should be considered when symptoms are chronic over at least 2 years, even if they are less severe, while substance-induced depression and medication-related causes must be assessed through careful history, including alcohol use and agents such as corticosteroids. Medical conditions such as hypothyroidism, anemia, and sleep disorders must also be ruled out, as they can mimic or worsen depressive symptoms. It is also important to distinguish depression from grief, where mood is tied to loss and self-esteem is preserved, versus major depression, where there is pervasive hopelessness and impairment. From a treatment perspective, accurate diagnosis directly guides management. Unipolar depression is treated with antidepressants and psychotherapy. Bipolar depression requires mood stabilizers or antipsychotics, and medical or substance-related causes require addressing the underlying condition. Finally, from a systems perspective, depression occurs within a relational context, where family conflict, parental depression, and social stressors can both contribute to and maintain symptoms, reinforcing the need to assess the whole patient. When diagnosing major depressive disorder, use the DIGFAST mnemonic to systematically assess symptoms, keeping in mind that the diagnosis requires either depressed mood or anhedonia, plus at least 4 additional symptoms from DIGFAST, present most of the day, nearly every day, for more than 2 weeks, and representing a clear change from the patient's baseline functioning. Sleep disturbance can be assessed by asking, "How have you been sleeping? Trouble falling asleep, staying asleep, or sleeping more than usual?" Interest refers to anhedonia, so ask, "Have you lost interest or pleasure in things you normally enjoy?" Guilt or worthlessness can be explored with, "Have you been feeling like a burden or overly guilty about things?" Energy is assessed by, "How has your energy level been?" Concentration can be evaluated with, "Are you having trouble focusing, making decisions, or remembering things?" Appetite or weight changes are assessed by asking, "Have you noticed any changes in your appetite or weight?" Psychomotor changes may be observed or assessed with, "Do you feel slowed down or more restless than usual?" And suicidal ideation must always be asked directly, such as, "Have you had thoughts of wanting to die or harming yourself?" In addition to symptom count, clinicians must assess severity, functional impairment, and safety, ensuring that symptoms are not better explained by a medical condition, substance use, or a history of mania or hypomania, as this structured approach ensures accurate diagnosis and appropriate treatment planning. When selecting an antidepressant, the decision should be symptom-driven and based on what problem you are trying to solve at the first visit rather than choosing randomly within a class. SSRIs such as sertraline or escitalopram are first line for most patients due to safety and tolerability, and are particularly useful when anxiety is prominent. A typical starting dose would be sertraline 25 to 50 milligrams, or escitalopram 5 to 10 milligrams, with titration every 1 to 2 weeks based on response. SNRIs such as venlafaxine or duloxetine are preferred when there is comorbid pain, fatigue, or more severe depression, but clinicians must monitor blood pressure, especially at higher doses. Bupropion is an activating option that targets low energy, poor concentration, and hypersomnia, making it a strong choice for patients with fatigue or sexual side effects from SSRIs. It is typically started at 150 milligrams daily and increased to 300 milligrams, but should be avoided in patients with seizure disorders, eating disorders, or significant anxiety or insomnia due to its activating properties. Mirtazapine is best for patients with insomnia, poor appetite, or weight loss, often started at 7.5 to 15 milligrams at night, but clinicians should anticipate weight gain and sedation. Trazodone is commonly used at low doses for sleep rather than as a primary antidepressant. If there is partial response after 4 to 6 weeks, augmentation strategies such as adding bupropion, lithium, or an atypical antipsychotic like aripiprazole should be considered, whereas lack of response after 6 to 8 weeks at a therapeutic dose should prompt switching. Medication selection should follow avoid by condition thinking. Avoid bupropion in seizure risk or eating disorders. Use caution with SNRIs in uncontrolled hypertension. Avoid sedating agents in patients with excessive daytime fatigue, and reassess for bipolar disorder if activation, agitation, or rapid mood shifts occur, as this may indicate an underlying bipolar spectrum illness rather than unipolar depression. When evaluating depression with psychotic features, the key distinction is the presence of delusions or hallucinations occurring in the context of a major depressive episode, often mood congruent with themes of guilt, worthlessness, poverty, or somatic illness, although mood-incongruent psychosis may indicate a more severe course. Patients may not report these symptoms unless asked directly, so clinicians should ask, Have you had any unusual beliefs or heard or seen things others do not? This condition is associated with greater severity, functional impairment, and significantly increased suicide risk, requiring urgent and aggressive treatment. First-line treatment is combination therapy with an antidepressant and an antipsychotic, as monotherapy with either is less effective. The most well-studied combination is fluoxetine plus olanzapine, available as the FDA-approved olanzapine-fluoxetine combination, with strong evidence for efficacy and relapse prevention. Other well-supported options include sertraline combined with olanzapine or risperidone and venlafaxine combined with quetiapine, particularly in more severe or treatment-resistant cases. In practice, clinicians often pair an SSRI with a second-generation antipsychotic such as olanzapine, risperidone, or quetiapine based on patient-specific factors, especially metabolic risk and tolerability. Electroconvulsive therapy is a highly effective and often preferred treatment in severe presentations, particularly when there is suicidality, poor oral intake, catatonia, or need for rapid response. Hospitalization should be strongly considered when there is safety risk or inability to care for self, and once remission is achieved, continuation of both antidepressant and antipsychotic is typically required for a period of time to reduce relapse risk. Electroconvulsive therapy should be considered a first-line intervention in specific high-risk and treatment-resistant scenarios, not a last resort, particularly in severe depression with psychotic features, active suicidality with intent, catatonia, or when patients are not eating, drinking, or taking medications. It is also used off-label in conditions such as treatment-resistant bipolar depression, severe mania, neuroleptic malignant syndrome, and refractory agitation, especially when rapid stabilization is required. The best candidates are patients who need a rapid response, have failed multiple medication trials, cannot tolerate medications, are pregnant, or have a history of prior positive response to ECT. Treatment is delivered under general anesthesia 2 to 3 times per week for a total of 6 to 12 treatments, with early improvement often seen in sleep and appetite before mood improves, and response rates in psychotic depression reaching up to 70 to 90%. On the inpatient unit, management includes ensuring medical clearance, maintaining NPO status prior to treatment, holding medications that increase seizure thresholds such as benzodiazepines or anticonvulsants, monitoring for post-treatment confusion and fall risk, and coordinating closely with anesthesia and psychiatry teams. Electrode placement is typically right unilateral initially to minimize cognitive side effects, with bilateral placement used in more severe or non-responsive cases. When discussing ECT with patients and families, it is important to address stigma directly and frame it as a safe, evidence-based, and often life-saving treatment. For example, stating, "This is the most effective treatment we have for severe depression when we need a faster response than medications can provide," while also reviewing risks such as temporary memory impairment in a clear and reassuring manner. ECT is not a one-time cure, and patients require continuation treatment with medications, maintenance ECT, or both to prevent relapse, making follow-up planning essential from the beginning. Transcranial magnetic stimulation, TMS, is a non-invasive neuromodulation treatment for depression that should be considered in patients with treatment-resistant major depressive disorder, particularly after failure of at least 1 to 2 adequate antidepressant trials or in patients who cannot tolerate medications due to side effects. Unlike ECT, TMS does not require anesthesia and does not induce a seizure. Instead, it uses focused magnetic pulses applied to the left dorsolateral prefrontal cortex to modulate neural activity in mood-regulating circuits. Treatments are typically administered 5 days per week for 4 to 6 weeks, with each session lasting about 20 to 30 minutes. And newer protocols, such as intermittent theta burst stimulation, can shorten sessions to just a few minutes. The best candidates are patients with moderate to severe depression without psychotic features, those who prefer a non-pharmacologic option, or those who have experienced intolerable side effects from medications. TMS is generally not appropriate for psychotic depression or cases requiring rapid stabilization, where ECT would be preferred. Response rates are typically 25 to 65%, with remission rates around 14 to 37%, which is lower than ECT but still clinically meaningful, especially given its favorable side effect profile. The most common side effects are scalp discomfort or headache, and TMS does not cause cognitive impairment or memory loss, making it an attractive option for patients concerned about those risks. On a practical level, patients remain awake and can resume normal activities immediately after treatment, which improves adherence and acceptability. Contraindications include the presence of metallic implants in or near the head, such as aneurysm clips or cochlear implants, due to the magnetic field. When discussing TMS with patients, it is helpful to frame it as a well-tolerated, evidence-based option for depression that has not responded to medications. For example, this is a treatment that uses targeted magnetic stimulation to activate areas of the brain involved in mood without the systemic side effects of medications, while also setting expectations that improvement is gradual over several weeks, and that continuation strategies, including medications or maintenance TMS, may be needed to sustain response. TMS protocols vary by intensity, duration, and delivery model, and should be understood as distinct options rather than a single treatment. Standard TMS typically uses high-frequency stimulation at 10 Hz over the left dorsolateral prefrontal cortex, delivered in sessions lasting about 20 to 40 minutes, 5 days per week for 4 to 6 weeks, and remains the most established and widely available approach. Intermittent theta burst stimulation is a shorter protocol using patterned bursts of stimulation, usually completed in 3 to 10 minutes per session, with comparable efficacy to standard TMS and improved efficiency, making it increasingly adopted in clinical settings. The SAINT protocol, an accelerated form of TMS, delivers multiple sessions per day over several consecutive days, allowing for a much shorter overall treatment course and showing high remission rates in early studies, but it remains limited in availability and is not yet standard practice. At-home TMS is an emerging option designed to increase access by allowing patients to self-administer treatment under guidance, though it is still under investigation and lacks the same level of standardization and evidence as in-clinic protocols. Recent findings from the Ascertain TRD trials support the use of TMS earlier in the treatment algorithm, demonstrating improved outcomes compared to switching antidepressants or augmenting with aripiprazole in patients with treatment-resistant depression. Patient selection is critical. Ideal candidates include those with treatment-resistant major depressive disorder after 1 to 2 failed medication trials, those who cannot tolerate medications, or those who prefer a non-pharmacologic option, while TMS is not appropriate for patients requiring rapid stabilization, such as those with psychotic depression or severe suicidality, where ECT is preferred, or in patients with contraindicated metallic implants near the head. The key takeaway is that TMS offers multiple protocol options with varying intensity and duration and should be selected based on patient needs, access, and clinical urgency. TMS in the inpatient setting presents unique logistical and clinical challenges that differ significantly from outpatient use, and in most facilities it is not routinely implemented due to these barriers. First, TMS requires daily treatments over several weeks, which does not align well with the typically shorter length of inpatient stays, making it difficult to complete a full treatment course during hospitalization. Second, access to TMS equipment is often limited to outpatient or specialized centers, requiring coordination for off-unit transport or transfer, which introduces safety, staffing, and scheduling challenges. Third, many inpatient populations include patients with acute suicidality, psychosis, agitation, or cognitive impairment, who are often poor candidates for TMS and instead require faster-acting interventions such as ECT or medication stabilization. From a workflow perspective, patients must be able to sit still and tolerate the procedure, and missed sessions due to acuity, refusal, or medical instability can reduce treatment effectiveness. There are also administrative barriers, including insurance authorization, documentation of prior treatment failures, and coordination of care across inpatient and outpatient teams. When TMS is initiated during hospitalization, it is often done as a bridge to outpatient continuation, requiring clear discharge planning, scheduling of follow-up sessions, and patient education to ensure adherence. The key takeaway is that while TMS is an effective treatment for depression, its structure and requirements make it better suited for outpatient settings, and inpatient use is typically limited to carefully selected, stable patients with strong continuity plans in place. Accurate diagnosis drives treatment, and the most critical distinction is ruling out bipolar disorder before treating depression, as misdiagnosis can lead to inappropriate antidepressant use and clinical worsening. Use structured approaches such as DIGFAST to screen for mania and CGCAPS to assess depression, ensuring you do not miss key symptoms, while also evaluating severity, functional impairment, and suicide risk at every visit. Treatment must match the diagnosis. Unipolar depression is treated with antidepressants. Bipolar disorder requires mood stabilizers and/or antipsychotics, and depression with psychotic features requires combination antidepressant and antipsychotic therapy, or ECT. Antidepressant selection should be symptom-driven and follow avoid by condition principles, with ongoing reassessment rather than static prescribing. In more severe or high-risk cases, particularly with psychotic features, suicidality, or need for rapid stabilization, ECT should be considered early as the most effective and fastest-acting treatment rather than a last resort. For treatment-resistant depression in stable patients, TMS offers an evidence-based, well-tolerated, non-pharmacologic option when medications are ineffective or not tolerated, but it is not appropriate for patients requiring urgent intervention. The key clinical takeaway is to think in terms of diagnosis, severity, and treatment alignment. Use DIGFAST and CGCAPS to identify the syndrome correctly, then match the patient to the appropriate intervention, medications, ECT, or TMS, using a stepwise but flexible approach to optimize outcomes. As you move forward in clinical practice, remember that your role is not just to identify symptoms, but to understand patterns, risk, and the full clinical picture in front of you. Mood disorders are highly treatable, but only when we take the time to fully explore the diagnosis, choose interventions intentionally, and reassess continuously. The difference between a good clinician and an excellent one is the ability to adjust when the patient's needs change. Ask questions that uncover meaning, not just symptoms, with the goal of changing the trajectory of a patient's life.